I hope everyone had a great lunch. We are going to resume our conversation. My name is Rebecca Gilbert. I'm Chief Mission Officer at APDA. Our table is there. Parkinson Foundation is there. We are so happy that we coordinated with Parkinson Foundation and JCC to have a collaborative event. That is a really big deal, and we're really, really happy that this worked out. So thanks, everyone, for coming. I want to mention in terms of some of the issues that were brought up at the last panel, Caroline also mentioning about how important the associations are to help with answering those questions. I want to point out specifically that APDA has publications regarding nutrition that may be interesting for people to check out, as well as 2 storybooks, one about a mom with Parkinson's, one about a grandpa with Parkinson's, that may be useful for people with children who want to have tools to share their story with their children. So check out some of that stuff on our table. And more generally, our website, apdaparkinson.org, has maybe some answers to some of your questions. So feel free to come over, ask specific questions, or to check out our information after. So this panel is a very pointed panel. These 3 individuals are healthcare professionals who have Parkinson's disease. And so that gives a different perspective, and we wanted to really mine the brains of these 3 people about how they navigated their own Parkinson's, having a little bit more health information that maybe the general person doesn't have. So what and I also want to mention, who have not been mentioned enough yet, is Kazim. Can you wave, Kazim? This whole concept, the concept that sort of the for us, by us, that we're really going to hear from people with young onset. We're not going to just have talking heads that talk about different topics and you guys have to listen, but really get the information from people with young onset to talk to other people with young onset. That's really was Kazim's brainchild, and I really want to acknowledge that. And so on that note, I would like our panelists to introduce themselves, and then we'll get started. So.
Hi, everybody. Thanks so much for having me. My name is Becca Miller. I'm a clinical psychologist and person with Parkinson's. So I first had symptoms around age 28, then diagnosed at age 39, and I'm now 51. Oh, my God. So time flies when you have Parkinson's. So I live in New Haven, Connecticut, and I work as a clinical psychologist at the Yale School of Medicine in a mental health clinic. So my work is not specific to Parkinson's at all. I work with people with serious mental illness, but I have a 12-year-old daughter who is amazing, and yeah, that's about it.
Hi there, I'm Liz Utterson. Thanks so much to Rebecca for inviting me and everyone here. I'm actually from St. Louis, so I'm not from the city, and I flew in yesterday, so thanks for having me. I'm a pediatric gastroenterologist, and I work at Washington University, so I'm very pediatric focused. Certainly, but I will say going through all the medical training, everybody in their going through education has something that doesn't quite make sense to them, whether it's math or whether it's language or reading or writing, what have you. For me, it was neurology, okay? And so I learned what I needed to learn, but I didn't really understand a lot about it. So when I was diagnosed, I actually thought I was having problems from doing scopes. So I thought I had the muscle memory of doing scope after scope after scope. And so I went to my doctor and I said, please give me a PT and an OT referral because I have workplace, repetitive motion issues. And he said, no, I think we need a scan of your brain. And I said, nah. I actually self-referred myself to a neurologist at Washington University and said, hey, can you just document that I have a normal neuro exam so I can just go to PT and OT? And they said, you don't have a normal neuro exam. So anyways, it's been quite a journey. And I'm learning along with everybody else too, but I appreciate, certainly having some people in each of our corners to help along this journey. Thank you.
Hi, my name is Randy Todd. Thank you very much for inviting me to speak on your panel. I'm a retired dentist that specialized in microsurgical endodontics. And as you can imagine, nobody wants a dentist with a shaky hand. But I'd like to point out the similarities and the differences between all of us here. I want you to follow my little project. Think of a number 1 to 10. Everybody think of that number. Don't tell anybody. Multiply that number by 9. Got it? Okay. Add the two numbers of your answer together, and then subtract 5 from that number. Okay? Correlate an alphabetical letter to that number, such as if it's a 1, it's an A, it's a 2, it's a B, if it's a 3, and so on. Think of a country that begins with that letter. Okay? And then take the last letter of that country and think of an animal that corresponds to that letter. And finally, take the last letter of the animal and think of a fruit. Now, how many of you thought of Denmark, kangaroos, and oranges? What? See, so we are all alike.
That was great.
Okay.
All right. Well, that was awesome. Thank you, Randy. So on that note, I can't follow that. We have a list of questions that our panel came up with ahead of time. We're going to do kind of some interesting ideas about medicine as related to these three individuals, and then we'll take some audience questions. So the first question that I think may be of interest to our audience is, what is your advice in forming your medical team? There's a lot of talk about having a medical team to help you out. How do you approach that? You just got diagnosed with Parkinson's. What do you do? Becca?
Yeah, I think that's a challenging one. I just want to say, too, when I was first diagnosed, I thought it was psychosomatic. So I was like, oh, it must all be in my head, because I'm a psychologist. I was having trouble moving my hand to pick up my child when she was a baby, and I was like, oh, I must have issues and conflicts about that. So my training as a psychologist kind of got in the way in a big way. So I think forming my medical team, it's been a process over the years. So I've been diagnosed now for 12 years. I think, I had this idea that there would be this team waiting to kind of wrap around me and scoop me up and take care of me, and that really has not happened. It's been kind of piecemeal. It's been really on me to put it together. I think that it takes a lot of self-advocacy to get the kind of care that you need. So getting PT, making sure that I have an eye exam, making sure I get dermatology checks, all these things for specific aspects of Parkinson's, like that you're more at risk for melanoma if you have Parkinson's. So it's important to get a dermatology exam. Things like that are things that I kind of discovered on my own and through, looking up things on these organizations' websites, et cetera. So it takes some time. And I think it's also, as you develop different symptoms and different issues, that then you kind of bring more people onto your team. So that's been my experience.
So yeah, I'll be very honest. I was very disappointed with kind of the onset of my care, and I'm a healthcare professional, and I work at a great university, and certainly it was Washington University, and the first thing that they said to me was, the next time I see you will be 1 year. And I said, are you kidding me? Are you kidding me? The next thing is I put some messages in the portal. And I got to the point where the nurses wouldn't answer anything anymore, right? Because they tried to say, it sounds like you're a little anxious. And I was like, So they just send everything directly on to my neurologist. But I will say, and certainly my mother-in-law said, I bet you have a fantastic treatment team coming from WashU. And I said, really, it's me, myself, and I. So I definitely have learned to kind of build things, as Becca had said, over time. I will say that when I met with a physical therapist, I was kind of doing laps around the kind of lapping her a little bit when I was going around the thing. So I think the important part is not everything is necessary at the beginning. And it might be, certainly good to figure out one or two things to really focus on, because you don't need probably everything right away. And certainly, but I think we all do need support for sure.
I had a very different approach to it. When I was first diagnosed when I was 65, I just denied it. I don't know how many of you go through that stage as well. But it took 4 neurologist visits to finally convince me that I had, and Dr. Gilbert was the last one. But once I recognized that I did have a problem, I began to assemble a team of doctors, and I interviewed them, and they were kind of surprised that I was interviewing them. But I wanted to have a neurologist, I wanted to have a psychologist, I wanted to have a physical therapist, I wanted to have a PT, I wanted to have an ophthalmologist, and speech and hearing, and all different disciplines that were necessary to keep me in line. And I started off with them before I needed them, so that they had baselines. And then now that my tremors started to activate again, they knew where I came from, where I was. And I did the DBS early in the problem for the right side, but now I'm actually scheduled to have DBS done on the left side on December 1st. The first one was done in 2019. But it's important to have baselines of normal for you so that they can compare it and know when to make the decisions. And I think that the idea that DBS is a terrific modality for treatment, it shouldn't be that you have to wait 8 to 10 years to get that treatment.
So thank you very much for that. I think the takeaway is that you have to be a self-advocate. You have to really work, unfortunately, probably more than you should, and that you need to have all the options sort of in your head and be able to discuss them with your doctor. So that's interesting, unfortunate, I think, in some regards. So that brings us to our next question, which is, what is your treatment approach? I.e., when do you feel like I'm going to say something to my doctor, things aren't going well, I need to make a change, as opposed to kind of keeping along what you're doing now? Do you have sort of guidelines for that?
I'm lucky to have a really collaborative relationship with my neurologist. I'll say that it took me a while to find a neurologist that I wanted to work with or felt comfortable with, and that was really important in being able to kind of move to a different neurologist when I just wasn't getting along with the first one who was assigned to me. In terms of treatment approach, I mean, I think it's a process. That's a very psychologist thing to say, but it takes a while. I think when I was considering DBS surgery, which I had one side done in 2021, the second side done in 2024, in 2021, when I was considering it, I had to kind of come to terms with it for myself. So I was keeping a little, on my iPhone, keeping a little notes list of when I was on, when I was off, all this kind of stuff, when I had dyskinesia. So I'm, had like 3 days worth of meticulous notes that I then, in a dyskinetic moment, tapped and deleted all at once. And I was like, oh, well, maybe this is a sign that there is some stuff going on that I need to take care of. Yeah. So yeah.
Been there, done that.
Liz, anything about treatment changes?
Yeah, so I was very fortunate to seek a second opinion in Nashville at Vanderbilt, and actually a protege of Dr. Gilbert's was Dr. Britt Stone. And I remember her saying to me, "You're one of us. As long as you want to keep doing what you're doing, we're here to make it happen." And I think that was very meaningful to me. I'm the person who, of the group that hasn't had DBS, and I take Cinemet, but I actually had to take 3 weeks off back in June from work. I took FMLA because I was really nauseous. And I have to take a variety of pre-medications and things like that. So that's one thing I remember hearing my doctor say the first visit too, you should start medicine. The only main symptom is nausea, no big deal. And I kind of paused and thought, I was really sick with my son when I was pregnant. I had hyperemesis, and I thought, it actually is a big deal if it, you know what I mean? Certainly I found the nausea way more disabling than my symptoms at work. So I think, certainly sometimes you have to stand down. And I remember talking to my clinical director about this, like I need to take a few weeks off. And he said, okay, I don't know if you need 3 weeks, but I suppose if you just took 1 week and then you needed more, maybe you shouldn't. And I thought, I vomited for 2 weeks. And finally, the third week, I felt like I was making some headway. I can't work through that. Nobody wants me to work through that. And, quite honestly, it's just not good medication or medical practice to be working during something like that. So I think you have to advocate for yourself in terms of trying to figure out what is best for you in terms of what you want to continue doing and how to make that happen.
Want to comment on why one side and how you're deciding this second?
Personally, I think that the team that you develop to work with should be there to assist you when you have a question. And that far too often you call up and they call you back that night, they call you the next day or the next week. But the process of answering questions will lead to the process of making changes in your treatment, so that by having the baselines that you would start with, you get an idea of, okay, now I'm developing nausea or I'm developing some other condition. It might be time to change something in the treatment to overcome that new issue. But without the baseline, without the open dialogue with your team, you can't have that.
Thank you very much. So one of the other issues that we talked about was hospitalization and being hospitalized with Parkinson's, and some experiences that you may want to share. I know Becca has one.
Yeah. So I had, this was 2019. I was aware of, issues facing people with Parkinson's in the hospital, and I was super arrogant about it. I was like, this won't happen to me. I'm younger. I'm, well-spoken. I'll advocate for myself. It'll be fine. It was a complete disaster. I had every problem that was described in the literature, including contraindicated medications, just the wrong medications, missing medications, everything that I thought would not happen to me happened to me. So that's why I carry this, and this is at the back table, but the hospital safety guide is so great. Mine is very beaten up because it's with me all the time in my backpack. But it is so helpful. And even when I had my DBS surgery, I still got contraindicated medications on the neurology floor as a person who just had brain surgery. So I actually had my brother take this booklet to the nurse's station to tell them I can't take this medication. So I think and the Parkinson's Foundation has done such a great job on this issue, and they're working towards addressing it at the systems level, at the hospital level, at the kind of medical record level, but it's not there yet. And it's going to be a while. So really, as a patient, you have to be knowledgeable and ready to, make a fuss, I guess.
I'm not sure. Have you been in the
So
hospital?
fortunately, I've not been in the hospital, but I am in the PPMI study through Michael J. Fox Foundation, and I don't know if any of the rest of you have done that, but I've had 2 spinal taps so far, and I've had 2 spinal headaches. So I had to have 2 blood patches, and I remember going to these places. The one, my neurologist set up for me, go to this pain clinic and get your blood patch and such, and I was at the registration desk, and I said, I'm going to go and lay down in the middle of the room, the waiting room, just because I can't sit up anymore. And they were like, oh, let's get you back. But then the most recent experience was at Barnes Jewish Hospital emergency department, which most of us don't want to actually have to go and visit that place, and there's a reason for it, but it was on a Sunday morning where my neurologist got, somebody, one of the anesthesiologists, to do a blood patch on me, but it still ended up being 2 to 3 hours. And I remember hearing from the people in the waiting room, you cannot lay down here, because I was trying to slink down into a chair. And I remember just sobbing and sobbing and sobbing until they took me back. And you know what I mean? I think it's stressful enough, but I think there's lots of opportunities for improvements around.
Well, maybe do you want to say something about hospitalization?
I think it's important for you all to read the hospital safety guide. The Parkinson's Foundation, up until a couple of years ago, ran a program called Aware and Care. Because the problem of people in hospitals not receiving proper medication, not receiving medication on time, not receiving the medication that their neurologist prescribed for them, and winding up with complications that wound up in hospital stays that lingered for weeks. And we can be our own best advocate, but even when you try your hardest, it's not necessarily going to be effective. So be very much aware of the problems that exist when you face a hospitalization of either a planned hospitalization or an emergency. And that you can get from the hospitalization safety guide.
So I'd like to jump from Liz's comments about being in the PPMI study. This is a long-term observational study that Michael J. Fox Foundation runs. And not everybody agrees to get the lumbar puncture, and thank you very much for doing that. That's additional information that can be gleaned for the study. So I wanted to talk more broadly about being involved in clinical trials or clinical studies. So they're the observational kind. You're not taking a medication. You're just giving your data to a big data consortium so that people can study people with Parkinson's. And then there are clinical trials where you're given an intervention. So do any of you have clinical trial experience, meaning participated in a clinical trial? So how did you find out about it? What was your experience? Anybody want to jump in there?
I participated in the clinical trials that are brought to us through the Rock Steady boxing program. Dr. Rose Gallagher runs a couple of different clinical studies, and we get introduced to participate in them that way. But you get bombarded with available studies on the internet or on your phone, things like that.
Yeah, I remember when I first got diagnosed at Columbia, and I walked from the clinic room to the blood draw station so that I could participate in a clinical study, because I thought, it's like, if we have to have this, why not make your suffering and useful in some way? I think it's really important to figure out what your limits are on what you're willing to do, how far you can travel, how much time you can spend when looking at different clinical trials and deciding whether or not to participate. But I encourage everyone to try and find something that they can do, just because it's so important, and that there are a number of research studies that are funded and then can't be completed because they can't find enough participants. So it's so important to keep an eye out. I don't know. I used in the past Fox Trial Finder to try and find studies. Looking on the internet, there are a number of different major medical centers that have studies going on that you can look into. But I think it's so important to participate if you can.
Yeah, and APDA has a clinical trials website that lists some interesting clinical trials as well. Fox Trial Finder is a great option. And then asking your doctor, I think, is probably the best. And I think it's important to note that some of the clinical trials are observational. You're not doing any intervention. Some are taking a medication or a surgery, and some are exercise, as you mentioned, exercise intervention. And that's very important, too.
I think you have to be cautious and weigh the risks versus the benefits, because some people study anything.
Right. So just to be clear about that, clinical trials do need to have an extremely rigorous process to get approved. And so what you don't want to do is enter something that isn't really a clinical trial. And that's I think where you have to be careful. But once it's has IRB approval, there really are a lot of safety guards in place to make sure that nothing happens that you're not fully aware of. And of course, there's always going to be potential for side effects that you will be able to report. So the next thing that we'd like to discuss before we take questions from the audience is, does anyone have experience with the new biomarkers? So it used to be, and still is to a large degree, that you get a diagnosis of Parkinson's based on clinical exam. Over the past number of years, there have been tests that have been introduced commercially, a lumbar puncture test, a skin biopsy test, and then what's been available for a while is a imaging test, a DAT scan. Does anyone have experience with these other tests that helped in their diagnosis of Parkinson's disease?
Sure. So just to comment about the PPMI study too, just so you guys know, they don't have it at WashU, so I actually go to Kansas City. They have it at University of Kansas there. So, and that's 3.5 hours away, so I agree, you have to kind of decide what you're gonna, where you're going to go, what you're going to do, and things like that. But it actually was really empowering to be in this study for me because I'll be honest, at WashU, they don't believe in DAT scans. So I didn't get a DAT scan. I got a brain MRI, it was normal. I got a skin biopsy, it was actually normal. And so, they were like, but we still think this is our clinical impression. When they talk about Parkinsonism, sometimes there's other things that can be, certainly come from this. And I've found over time that a lot of those things are worse than Parkinson's. And so through my time in the PPMI, even though I got the spinal headaches, I had to have the blood patches and things, I was able to see that I actually have the alpha-syn nuclease protein in my CSF. And it's the one that's particular for kind of run-of-the-mill Parkinson's. So there's things along the way that make you happy that, you know what I mean, you don't have something worse, but I was very happy to have some more definitive information, and certainly that study helped.
No experience.
Okay, sounds good. So we heard a lot about exercise on our first panel. Panelists, and there was a lot of pro-exercise, and certainly we agree with that. But there are definitely people that aren't natural exercisers, that don't love exercising. So maybe we talk a little bit about that tug of war. So we have some exercisers here and some people that it's a little harder for. So let's start with Becca.
Yeah, I hate exercise. Let's just put it out there. It's like the most ironic thing to me that I got a disease where exercise is the only disease-modifying treatment. So I've tried to work really hard to find things that I like to do or that I can force myself to do. So for example, most recently, I got a dog, and I walk my daughter to the bus stop every day, and then I go try and jog with the dog, and she likes it, and I like it, so that is a bonus. I mean, once I get doing it, it's okay, I guess. It's not great, but I like that I do it afterwards. I like that I have done it.
Liz.
So I actually have always liked to exercise, but all through medical school and everything, I'd say, I'll exercise when all the work is done. And that didn't pan out very well because there's always more work to do. So I actually, this sounds weird, but I like to it's the best excuse that I feel like I needed to make exercise a part of my everyday life at this point. And I really find that it helps, certainly my mental health. I've gotten to the point where if I don't exercise in the day, even if I have a really busy clinic day or something like that, and I'm emotionally exhausted, if I'm not physically tired, I don't sleep very well. And so I feel like there's lots of different layers to keep that going.
I never exercised. I thought it was something only you did if you were involved in a sport, and I wasn't really an athletic person, so I never exercised. And then, boom, Parkinson's. Only modifying effect that you can have on this disease is exercise. Well, I went from 0 to 60 overnight, and now I exercise 3 times a week with rock steady boxing, twice a week with Hofstra University's program on exercise and Parkinson's, and I start my day at 5 a.m. with a 10-mile ride on my Peloton, and I try to accomplish between 60 and 100 push-ups a day. So I really went from 0 to 60.
Very impressive. Let's talk a little bit about Liz and Becca, your experiences as a woman with Parkinson's disease. Any specific stories you might want to share about that particular angle of your illness?
Sure. I think my diagnosis was delayed, I think both because I don't have a tremor, but also because being a woman and being someone with a history of mental illness. So I have had depression and psychosis. And so it took a good 10 years for me to be diagnosed. But I think that was also from my own experiences of sexism in the medical sphere, in the medical space. So leading me to doubt myself and my symptoms. I think also I've never been asked by a neurologist about my menstrual cycle and hormonal effects in terms of my symptoms. So that just has never been something that's come up. So I think that there's new research. There was just a paper that came out showing that I think it was that women experience more dyskinesias early on. So there are different effects by sex. So I think that it's so important that we continue to research that and look at that.
Because I'm in a because I'm in a procedural field, I guess, I wanted to make sure that people knew about this so that they weren't like the other people had talked about. They weren't saying, look at her, why is she still doing that procedure? That's not safe, those types of things. And I'm of the mind that I practice very safely and that safety comes first. And so I would not, if I didn't think I could do a procedure well on a patient, especially a pediatric patient, I wouldn't do it. That being said, I feel like I've gotten from being kind of forthright with that, certainly within my medical center, certainly talking to the chief of pediatrics recently, and I, see a lot of patients, and so I bring in quite a bit of revenue, but I said, I really am gonna need some help. And I have trouble typing at times, and especially even just when patients are in the room, and then I'm a little bit more, they're looking at me like, you have a problem with, I've had people say, do you have a problem with your hand? And I said, yeah, I have an injury. And I said, I really would like it if I could possibly get a scribe. And he said, you're so productive, so yeah, no problem. But he said, I'm going to be honest with you, there's a bunch of things that are going to come down the pike that we're not going to be able to do for you. And I was like, would you have said that to a man? You know what I mean? Would you have said that? But I stopped myself from saying, well, should we just talk about those things now? Let's, just let it out. But he also shared with me, he said too, I don't know if I were you, I think I put my running shoes on and go run until I fell into a ditch.
What?
So, you know what I mean? I think I've definitely, whether it's, certainly on the woman's side, or this would be anybody, I think, we just have to be really, really thoughtful that, people, and I like Dr. Stone so much because she was like, as long as you want to do this, I'm here to help you make it happen. And, I think it's one of those things that I think people just need to provide some extra empathy would be a good thing.
Wow, that's some story. Last question, and then of ours, and then we'll take audience questions, which is, what is your advice to the audience about a therapy that maybe Western medicine hasn't provided? Maybe something that someone has told you about, or you heard in the grapevine, or you found on a website. What kind of advice do you give yourself about those type of treatments, and what would you share with the audience?
Go ahead.
I kind of come from, if it doesn't hurt something, then maybe it'd be okay to try, but I'm very scientifically literature driven. And so if I don't see some sort of utility in the literature, it's a little bit hard for me, but I am fairly impressionable. But I always tell my patients it needs to not hurt in a variety of ways, meaning no significant side effects, doesn't hurt your pocketbook, different things like that. But I'm very much open to adjunctive therapies that go with like medications for my patients with inflammatory bowel disease. If they certainly want to do something and with respect to acupuncture or a variety of different things, I'm certainly open to it, but it just needs to not hurt in ways that, could be problematic.
I would try anything to get rid of Parkinson's. But when, before I had the DBS, I remember doing a celery drink. Well, I think we juiced a full head of celery a day, and I would drink the celery juice, and after about 2 to 3 weeks of starting to look kind of green, I stopped that. And then when the neurologist was very progressive that I was working with, and he suggested, well, maybe you want to try marijuana. So it turns out that it took enormous amount of marijuana to get me to feel anything for the Parkinson's, but I was so stoned I could barely walk out of the house. And I mean, there were a number of different studies that I would read about. I was an avid reader of studies, but nothing other than the DBS really had any impact. But again, when it goes back to figuring out how to assess whether or not you'll try it, you have to weigh the risk and the reward and go from there.
Yeah, I would agree. I remember when I was first diagnosed, I would be so excited to see these headlines that would come across, such and such treatment for Parkinson's, blah, blah, blah. And every time I would click on them, it would be like, in mouse studies, they found blah, blah, blah. And I'm like, oh, man, this is not, happening quite fast enough. But I think that, science takes a long time, and that that if it's not hurting you, if there are no known, and I think the pocketbook piece is especially important, because I think that all of us want there to be something that will come about, and so that it leaves us vulnerable in certain kinds of ways, and so for that reason, I'm pretty conservative for myself, that I want there to be some kind of evidence before I really put myself or my dollars out there for something. So that would be my advice.
Thank you very much. We are now going to take audience questions. So if you've written a question down, you can hand it in to the woman in the green sweater. And in the meantime, we will take a question from the Zoom audience. And the question is, can you more specifically say what the main differences are in alternate therapies? I think the asker is talking about deep brain stimulation and focused ultrasound. And maybe, Randy, you can address what actually happened before and after DBS. What made it so different for you?
Well, DBS, for those of you that may not be familiar with it, mimics the effects of dopamine on the brain, and therefore helps to arrest the symptoms that you're showing. The procedure is divided into 3 parts: the placement of the probe itself. Then you come back a week to 2 weeks later, and they place a generator, which is similar to a pacemaker, in your chest, and wire it to the probe. And then about a week, 2 weeks later, you begin the neuromodulation processing problem of adjusting it so that it arrests your particular problem. It is not, like you were told earlier, it's not a painful procedure at all. There aren't a lot of nerve endings in the brain. That sounds funny, but they're not there. I took 2 Tylenol at the bequest of the nurse. I really didn't need it, but that was the maximum amount of pain medication I took postoperatively. When they activate the generator, and you suddenly, like a light switch, arrest the symptoms that you were having, it's quite remarkable.
Great. So we have a great question here from our audience, and maybe, Liz, you can answer this. What questions should you ask to determine if you should enter a clinical trial? How did it come about that you joined the PPMI?
Yeah, so I actually, just being in medicine, it, certainly helped for me to know, certainly that I wanted to enter that. And I wanted to do something, but I didn't think I was ready for a therapeutic trial, things like that, because I hadn't really started medications or something, although that is not a bad thing for starting trials. It's nice to not be on medications. But I think, certainly I thought, if nothing else, that my work would be hard to do it with my work, but on the other side, I thought that my work would appreciate me being interested in this aspect of my disease. So I thought that certainly would fly. And I thought, they're making great headway on things like biomarkers and things like that. And so I was certainly felt like being a part of that was going to be really helpful. I'm hoping anyway. But I think talking to your doctor, because I talked to my doctor and I said, what about the Michael J. Fox Foundation? He said, it's a good foundation. Like it's really good. And I felt like it was the right thing for me to do at the time.
Great. So just wanted to highlight your point about not being on medication. So that's, if somebody hasn't started medication, there may be clinical trials specifically for people who are not on medication for a potential disease-modifying agent. So yeah, if that's you, ask your doctor about that. Something I had forgot to mention before about women, we're going to have a tabletop discussion about women and PD run by a researcher who researches women and PD. So if that's you, look out for that at 3 o'clock.
I was just going to say about the clinical trials, I think first is finding out if you can be included. So what's the inclusion criteria? So are you eligible to even be a participant? And then figuring out the time commitment, is it travel? Is there reimbursement? And then what it involves in terms of like the risk and benefit to you. So for example, I would have loved to join PPMI, but the skin punch and the lumbar puncture was too much for me, worrying as a single parent that I wouldn't be able to kind of function if I had those side effects. So that was individual to me, but a reason that I wouldn't join that trial, whereas the exercise trial that I participated in, and where I had to wear basically an ankle bracelet, like I was on parole, to measure my activity, but that was something that I could do.
Great. Any other questions from the audience that we have not addressed? Okay.
Hi, me again.
Yeah.
Just maybe you want to explain what HIFU is?
Yeah. So earlier, somebody mentioned what is the difference between deep brain stimulation and HIFU. HIFU is high-intensity focused ultrasound. Focused ultrasound is a procedure that is not specific to Parkinson's. Neither is deep brain stimulation either. But focused ultrasound is a procedure in which you wear this helmet. It's correlated to your MRI. And basically, ultrasound waves are emitted from this helmet, and they converge on a very, very specific tiny area in the brain. And all the convergence leads to a little area in the brain that's heated up, and a lesion is formed. So a lesion is formed within the brain without surgery. And the idea is that there's abnormal circuitry in Parkinson's disease. The nerves are talking to each other in an abnormal way due to the lack of dopamine. And by burning a tiny little hole in the brain, you restore normal circuitry. So in a way, it is similar to deep brain stimulation. Stimulation is stimulating a specific part of the brain to restore normal circuitry. Focused ultrasound is destroying a little part of the brain to restore normal circuitry. So they're similar. deep brain stimulation has been around for much longer and has been approved for much longer. Focused ultrasound is around 5 years, and deep brain stimulation is 20 plus. So there's a lot more experience. Many more patients have it, and it works really well for many people. Both have similar indications at this point, which is tremor control or control of Parkinson's symptoms in a similar manner to what levodopa or the medication would do. And so really your anticipated response to both these procedures mimics what your response would be to the medication for the most part. It is true that in certain situations, a doctor may choose focused ultrasound for you if tremor is more of an issue than all the other Parkinson's symptoms, but not necessarily. There are other specific things to look out for, like in focused ultrasound, you need a certain thickness of your skull. If it's too thick, you can't do it. Things like that you wouldn't necessarily know. And so it really does require a conversation with your doctor about these two procedures and which one would benefit you. The biggest difference is that focused ultrasound is a lesion. You have it, you go home. There's no equipment left in your body, but it can't be adjusted. You would need to have the procedure again. Deep brain stimulation, you do have something left in your body. You do have wires and a pacemaker left in your body, but it can be adjusted. And so there's that, it's not one and done.
And it can be reversed, right?
And it can also be taken out. Yeah. I have been told that we have to stop. Oh, one more question. Okay, one more question. So the first one is deep brain stimulation, DBS. The second one is focused ultrasound, which is high intensity focused ultrasound, or HIFU. TMS is something else entirely, which we have not discussed, which has a lot less data that it's as effective as the other two.
I heard the gentleman speak about Rocksteady, but did anyone else try any of the other Parkinson-specific exercise programs? And what was your thought about her? Because I know myself, when I'm in a good routine for one of those programs, when I miss a day, I get the same side effect as missing my med. So I was just wondering if you guys had the same experience.
So it's Parkinson-specific exercise classes, other than
I haven't done any, so I can't speak to that.
I haven't gotten to find a class that works for me with respect to time schedule and such yet, but I'm anxious to start it because I've heard so many good things about it, and there's lots of good literature about it.
I find a very similar response to what you're saying, is that if I miss a couple of days, I feel like I've missed medication, that I've revert backwards. It's a very dependent, you've become very dependent on it to maintain not progressing with the disease. But no matter what you do, Parkinson's is a progressive disease that you can't stop. You just want to slow it down.
Can I? Sorry. I was just going to say, I just wondered, do you see any patients at this time?
Yes, I see patients.
So the one thing I'd just say, just to tout her, so I've been to 2 different neurologists. Well, I've been to 3. Well, more than that. Anyway, but 2 neurologists have said that their work with Dr. Gilbert made them who they are today in terms of Dr. Bridgestone, yeah. And one of the PPMI study doctors at KU. And so I just wanted everybody to know that in your region, you have a wonderful doctor that has inspired other doctors to go into this, and they're really good people.
On that note, we are going to have to end our panel. But thank you so much to our 3 panelists. Amazing job. Thank you.